Good afternoon to both of you, Cheyenne and Annie Lemperis. It's my pleasure to welcome you once again to this review session. Let's go ahead and get started in the interest of time. Okay, so before I go further, I would like to ask you this question. All right. So the reason I ask you this question is there are some schools of thought still that prevails as far as do you hear um an echo? Do you all hear an echo at all? No? Okay. So if you don't hear an echo, that's fine. All right. So there's still some school of thought wherein they teach students that DKA or diabetic ketoacidosis is a complication of type 1 diabetes only. Now, I teach 600 students every Monday from around the world, mostly from Africa, Asia, and the Caribbean. And I always ask this question, and it just baffles me that a lot of people still think that DKA or diabetic ketoacidosis only occurs in type 1 diabetes. The answer to this question is that it occurs in both type 1 and in type 2 diabetes patients. And we'll explore more about this particular concept in a little bit. Okay? All right. So, our topic for today is diabetic ketoacidosis. And diabetic ketoacidosis is going to be an acute, major life threatening complication of diabetes. And it usually is going to be presented by hyperglycemia, which is high levels of glucose in the blood, as well as the presence of ketones in the blood as well as in the urine. So this is what's known as ketoacidosis and ketonuria. Now, whenever we have an absolute lack of lack of insulin, what's going to happen is that the body has got to look for other sources of energy. And those other sources of energy are going to be ketones to be employed as a fuel source. And the overproduction of ketones causes them to accumulate in the blood and the urine and therefore turn the blood acidic. So, although DKA occurs mainly in patients with type 1 diabetes, it is not uncommon in some patients who are also type 2 diabetic, who has type 2 diabetes mellitus. So, whenever we have diabetes mellitus, diabetic ketoacidosis, what's going to happen is that we're going to have an absolute or relative lack of insulin. And that's the reason why the body looks for other sources of energy. And when they look for other sources of energy, what's going to happen is there's going to be an increase in counter-regulatory hormones, meaning to say that the body tries to compensate. And what happens is that there's going to be an overproduction of glucagon, cortisol, growth hormone, and epinephrine. And at the same time, the liver will now look for free fatty acids in order to produce ketones to be the source of metabolic fuel. This causes metabolic acidosis. And then, of course, as a compensatory mechanism, the body will now have some respiratory compensations that will occur in the form of your Kussmaul's respirations. So before we go further, as far as the discussion of DKA, let's take a look at the pathophysiology as far as DKA is concerned. So we develop DKA, or diabetic ketoacidosis, when there is hyperglycemia. So what happens when there is hyperglycemia? There's going to be an increase in plasma osmolarity. So what does that mean? If this is your blood vessels and now you have a lot of sugar or glucose in the bloodstream, what's going to happen is, because the glucose are going to be large particles, they're now going to attract a lot of fluid into that area. That is what we mean when we say we increase plasma osmolarity. That means to say, therefore, that they have a pool of fluid to bring into the blood vessels. And so when they do that, so again, if this is the glucose, and this is the cell containing fluid or water, what's going to the fluid that is in the cell? The cell is going to be dehydrated because the fluid will be pulled into the vascular space. Okay? So that's exactly what it means by intracellular dehydration. And as a result of the increase in volume of blood in the blood vessels, you're now going to have diuresis. And this form of diuresis is what is known as osmotic diuresis, because this diuresis results from the drawing of fluid from the intracellular compartment. Okay, so you're going to have cellular dehydration. When you have cellular dehydration, right over here, and now you're going to have diuresis, you're now going to also have a decrease in your extracellular fluid volume. So it's not only the intracellular that's going to be dehydrated, but also the extracellular space. So the major problem then, when you're looking at diabetic ketoacidosis, is dehydration. If you could see in this illustration, we have now dehydrated the cell, and we also have dehydrated the extracellular compartment. So whenever you diurese, obviously you're going to lose a lot of electrolytes, and those electrolytes that are going to be very important are going to be sodium, potassium, phosphate, as well as magnesium. So in diabetic ketoacidosis, the challenge is not only dehydration, but also electrolyte imbalance. So two main things that's going to happen as a complication of this hyperglycemia. Thus, when you decrease extracellular fluid volume, you'll develop shock. And because of the decrease in volume, you're now going to decrease renal perfusion or glomerular filtration rate. And these would precipitate the development of acidosis, azotemia, as well as more glucose, because of the fact that you are not eliminating what is present in the urine. So this is going to be the characteristics of the pathophysiologic processes that occurs in diabetic ketoacidosis. So let's now talk about what are the causes of and the risk factors for diabetic ketoacidosis. Well, this occurs mainly in diabetic type 1, as we had said, but in 10 to 30% of cases, it also occurs in patients with diabetes type 2. And there are some risk factors that are going to be common and that can precipitate the development of extreme hyperglycemia and therefore ketoacidosis. And the most common scenarios are going to be a concomitant infection. Infection is a common inciting factor in DKA. So why is that? When you are have an infection, do you require more energy in order to deal with this infection? And the answer to that is yes. All right. So whenever we have a normal functioning, the normal function as far as metabolic fuel is concerned is the utilization of glucose. But in order for glucose to be utilized, so if this is glucose, glucose cannot enter the cell to serve as a fuel if there's no insulin, because glucose can only enter the cell with the presence of insulin. So it is by passive transport. Whenever you have normal secretions of insulin, therefore, the glucose can go in readily into the cells to be utilized as fuel. Now, however, if you're going to have an infection, you're going to require more metabolic energy. And if you have insufficient amounts of insulin, therefore, it's not going to have a metabolic fuel that usually is glucose. Because if you use glucose as a fuel, the metabolic waste product of glucose is carbon dioxide and water. My question is, can you eliminate carbon dioxide from the body? Yes. Majority of the carbon dioxide can be eliminated through the respiratory system and also through the skin. How about water? Yes, we can eliminate water through the kidney and also through the respiratory system and also through the skin. So we can eliminate those things. But when glucose is not available as fuel, like when you have insulin deficiency, as I have said, the body now looks for other sources of energy. And one such source of energy is going to be the production of ketones. And ketones cannot be eliminated readily from the body. And therefore, they're going to have a tendency of accumulating and thus will have a lot of physiologic effects that we will be describing, and namely cellular dehydration as well as extracellular dehydration. So infection, therefore, is going to be a #1 risk factor for the development of diabetic ketoacidosis. The other thing is that some patients who are diabetic might not adhere to their insulin therapy. And sometimes it's because they forgot to take it, or they are not reliant as far as or compliant with their insulin program. And therefore, misinsulin is a common cause, particularly in adolescents. These are the population wherein they usually neglect to get their insulin. The other thing is acute physiological stress. And when we say physiological stress, it might include illnesses that are major, such as myocardial infarction, sepsis, pancreatitis, or stress. And what happens in this particular instance is that you're going to have a lot of secretion of glucose and cortisol because it's a stress response, and therefore could also precipitate diabetic ketoacidosis. Certain medications are going to have the potential to affect carbohydrate metabolism. And those drugs that are very common in affecting their glucose levels are going to be antipsychotic agents like clozapine, olanzapine, and so on. Illicit drugs like cocaine and alcohol can do that too. And then, of course, others, and the major ones are your steroids, as well as your thiazide diuretics. So these are the most common drugs that are going to cause the precipitation of an increase in your glucocorticoids and therefore increases blood sugar. Now, it might also be the first symptom that might inform the patient that they are diabetic. In other words, some people don't know that they're diabetic until they develop diabetic ketoacidosis. So newly diagnosed, previously unknown diabetics, this may be caused by them not knowing that they have diabetes, and therefore this might be the initial clinical presentation in patients who previously were undiagnosed diabetics. Okay, so if you have diabetic ketoacidosis, what are the signs and symptoms that are going to be manifest? Well, the signs and symptoms of hyperglycemia are going to be very common. And what are the signs of hyperglycemia? If you remember, the three P's that oftentimes is associated with hyperglycemia, and they are going to be your polydipsia, meaning to say that they are going to be thirsty all the time, and that's because of the cellular dehydration. Polyphagia, which is an increase in the appetite, and lastly, polyuria. So these are the three P's associated with hyperglycemia. And so as you could see, the signs and symptoms would include these, and other symptoms would be those that reflects dehydration. And so what are the signs and symptoms of dehydration? Well, we could begin with the temperature. The temperature would be high or elevated. There would be dry skin or dry mucous membranes. And there's going to be a dry skin because the patient does not perspire. The reason they don't perspire is because they are dehydrated. And also, what's going to happen is that they could have labored respirations. And we'll talk more about the respiratory pattern that usually is associated with this particular situation. And these labored respirations are all called Kussmaul's breathing. This Kussmaul's breathing is a pattern wherein the patient's expiratory phase is going to be prolonged. So there's a prolongation of the expiratory phase. So why is that? Now, just look at me and say, if a patient does that, that means to say that they're trying to blow off excess carbon dioxide or acids. So it's a compensatory mechanism where the expiratory phase is going to be prolonged and exaggerated. Now, patients who have a lot of ketones in their body might also have a very sweet, fruity breath. And this is what's called an acetone breath. An acetone breath is, again, related to the fact that the patient has a lot of ketones in their body that cannot be eliminated. Tachycardia, as well as tachypnea or fast respirations associated with the prolonged expiratory phase, as well as abdominal pain, which is a very common complaint in patients with diabetic ketoacidosis. So I'm going to encircle this because this is a very, very common sign and symptom of patients with diabetic ketoacidosis. Okay, so now I have painted the picture of the pathophysiology of DKA, the signs and symptoms of DKA, and now let's take a look at the next question that we have over here. And let's see. All right, so the correct answer here is letter C. So again, you remember that when diabetics are sick, they require a lot more insulin. And so if they do not take more insulin when they're sick, that means to say that they will have hyperglycemia. So illness requires increase in insulin dose. So when a patient with diabetes is sick and they do not increase their insulin, they're going to have hyperglycemia. So this is the number one cause of diabetic ketoacidosis. Okay? All right, so let's go to how does this patient look? What are the findings as far as physical examination? On physical examination, most of these patients with ketoacidosis will present with features of hypovolemia. And this hypovolemia are going to be present resulting from the renal cause. Do you remember the polyuria? But it could also be as a result of gastrointestinal losses. They might develop vomiting and nausea. And so the findings are going to be manifest by association of symptoms of hypovolemia. So when you have hypovolemia, what is going to happen to your pulse? Well, your pulse is going to be rapid as a compensatory mechanism. You will have hypotension as a result of the findings of hypovolemia. And in addition to tachycardia as well as hypotension, what else are some of the other things that could reflect hypovolemia? Well, you could have dry skin, for example, or signs of dehydration. Your temperature could be increased as a result of it. Okay, so we could include an increase in temperature and then a dry skin and dry mucous membranes. All right, as a result of the hypovolemia, the patient could go into hypotension as well as in shock. And in addition to that, I have highlighted here the more common signs and symptoms, and they include your Kussmaul's breathing, as well as the patient complaining of a rapid weight loss. So those are some of the most common findings that you will see on physical examination. So nausea and vomiting, thirst, polyuria, abdominal pain, which we said was very common, as well as shortness of breath. And then, of course, the fruity odor, the tachypnea and Kussmaul's respirations. You can have abdominal tenderness, as well as mental status changes, which would include lethargy, obtundation, and even possibly coma. Okay? So those are the physical findings in patients with diabetic ketoacidosis. Now let's take a look at the laboratories that will be significantly abnormal and will assist us in the diagnosis for the presence of DKA. And of course, the number one finding is that you will have hyperglycemia. This is the typical finding of the presentation with DKA, but they can present with ranges of blood glucose. As you could see over here, it could be 250, and sometimes it might be more than 250. In addition to your hyperglycemia, this will be accompanied by metabolic acidosis. And so the number one thing is hyperglycemia plus acidosis. So if we took a look at the pH of the blood, you could see that the pH is going to be in the acidotic range. So usually it's going to be less than 7.3. And in addition to that, there's going to be presence of ketones, not only in the blood, but also in the urine. So as you could see over here, there's going to be serum ketones that are going to be positive, and there's going to be positive ketones as well in the urine. So those are the most important parameters as far as laboratory is concerned for the presence of diabetic ketoacidosis. Now, you might be thinking that blood gases are going to be very valuable in this particular instance, but the answer to that is actually not. What we rely more as far as laboratory test is concerned is an anion gap. The anion gap is a test that will tell us whether or not the acid is going to be caused by an excess accumulation of a lot of acid and not the loss of bicarbonate. So let me explain that. When we have acidosis, acidosis could be caused by two things. Either there's too much acid, and acid is hydrogen ions, or you could have the reason being a decrease in bicarbonate. Okay? So do you understand this concept first? Acidosis can be caused by two mechanisms. Either there's an accumulation of excess acid, or there's going to be a decrease in bicarbonate. Either one of these situations can cause acidosis. But in diabetic ketoacidosis, the problem is actually this one. So it's not the bicarbonate that's the problem, it's the accumulation of acid that is going to be the problem. And therefore, that's the one that we need to monitor to see if we're being effective in our treatment. So the explanation of anion gap is going to be this. So let's begin with basic understanding of your chemical processes in the body. Now, positively charged ions are called cations, and negatively charged ions are called anions. Now, can you give me a positively charged cation? Well, an example of that would be potassium. What else? What else are positively charged ions? Anybody? You can put it in the chat or you could talk. There's only 4 of you, so it's okay. Calcium, all right. And the most abundant one is actually sodium, right? Because this is 135 to 145, if you remember. And potassium is very less. It's 3.5 to 4.5. And calcium, 2. So the major electrolytes that are positively charged are actually your sodium and your potassium, right? So an example of a chloride, I mean, an ion would be chloride, because chloride is going to be negative. And then the other ones are going to be your bicarb, for example, and so on. So if you take a look at this, I'm going to magnify the slide. Okay. There is a rule in physiology that the number of positively charged ions should always be the same as the negatively charged ions in the body. So if it is not going to be the same, you're going to have an electrolyte disturbance. Okay? So what do I mean by that? Well, what I mean by that is, let's say this is sodium is 142, that's the number of cations, potassium 5, calcium is 5 and 3. So if you total that, 142 plus this 10 over here, that's 152. The number of cations in the body is 155. Do you understand that? So you always should have the same number of cations to the number of anions in order for homeostasis to occur. So what are some of the negatively charged ions in the body? Bicarb, which is 25, and chloride is 105, so that's 130. And if you look over here, we're going to magnify it so that you can see it. The other ones are phosphates, sulfates, and other organic acids. And they also would total 155. Do you get that so far? So the number of anions in the body is supposed to be always equal to the number of cations. So 155 to 155, that means to say that we are in homeostasis. Now, if you take a look at these areas over here, the small areas that are listed over here and over here, these are what we call unmeasured anions and cations. Unmeasured anions and cations. You can measure them, but because they're so negligible, we refer to them as unmeasured anions and cations. Okay, so I'd like for you to answer my question now. And my question is, which one has more unmeasured unmeasured substances? Is it the cations or the anions? Which one has more unmeasured substances? Is it your anions or cations? You can just look at the chart. Okay, so there are more unmeasured anions, right, than cations. See the difference between the two? Okay, so I'm going to draw something over here. The difference between the two, right, over here, is what is known as the anion gap. And so if you take a look at this, 5 plus 5 plus 3, that's 13. And then over here, 2 plus 1 plus 6, that's 9, plus 9, 29, 35. All right, so the difference between these two, did I do that? 16, 22, 23, 25, 25, I'm sorry. So that's 25. The gap is usually normally between 10 and 12 milliosmoles. Do you understand that? 25 minus 3 is equal to 2. See this 12? It's around 10 to 12. It's the difference between anions and cations. I'm not going to go forward if you don't, until you understand this, okay? So again, there are more unmeasured anions. So that's the normal. The normal anion gap, that's the gap, is the difference between the cations and the anions, is usually 10 to 12. So if you have an anion gap of 10 to 12, that means to say that your number of cations is equal to the number of anions, basically the same. Okay? Now, however, in patients who have metabolic acidosis, there's going to be a high anion gap when the reason of the gap is going to be accumulation of acid. So in acid retention, you will have a high anion gap acidosis. So let me give you an example. If normal anion gap is 10 to 12, and now my anion gap is 35, and another one is going to be 11, this one means to say that it is due to excess acid accumulation. This anion gap of 11 is a decrease in a bicarbonate. That is a normal anion gap acidosis. So you remember I said that acidosis could be caused by two things. One, high or an increase in acids, and the other one is a decrease in bicarbonate. Okay? So if we take a look at the anion gap, if the reason for the acidosis is the accumulation of acids, then we would have an anion gap that's over 12, 12 and above. And if it is bicarb, the anion gap will be between 10 to 12. All right? Is that clear? Are there any questions? I'm going to stop right there to see if you have any questions. No questions? All right. So the reason then that we monitor the anion gap in this situation in diabetic ketoacidosis is because it's a better parameter to see if the amount of acids are decreasing or increasing. Okay, so let's say that you are having a patient with an anion gap of 50. What kind of acidosis do we have? Is acidosis due to an increase in acids or is it a decrease in bicarb? If your anion gap is 50. Hello? You can answer in the chat box. If your anion gap is 50, what is the cause of the acidosis? Is the acidosis as a result of an accumulation of acid or is it a decrease in bicarbonate? Retention of acid. Very good. Thank you, Cheyenne. Yeah, because it is going to be high. So a high anion gap acidosis is due to acid retention. So if I'm treating this patient, I want to see whether or not we are improving. And so if our treatment is getting better, this 50 should go down to 40, 30, 20, and hopefully it will go to 10. Okay? So from now on, the purpose of this particular part of the lecture is to tell you that to evaluate the effectiveness of treatment in patients with DKA, we rely on a test, and that test is what is known as an anion gap. Okay? All right. So the other thing that is going to be present in patients with DKA is going to be your increase in serum osmolarity. What is osmolarity? Now, if we were to measure the amount of particles in a solution, so let's say that this one has 1, 2, 3, 4, 5, 3, 6 particles. And this one is going to have only 2 particles. Which one of these is going to be heavier? Is it A or B? Okay. And the answer to that is A. That means to say that there's more particles that is present in that solution. So when we have a normal volume of blood in the bloodstream, as well as fluid, and we compare that to so let's say that the water that's in here is 60 cc's and the water over here is 100 cc's. Which one is more concentrated? The one with the 60, right? This is what's called high osmolarity, meaning to say that there is going to be much more concentration of solutes in that solution. So we always measure that. And so when you have an increase in serum osmolarity, this is going to be a manifestation, therefore, of dehydration. Okay? Any questions so far? All right. So there are other tests that we rely, and they include the following right over here. Electrolytes are going to be very important. Your BUN and creatinine could also help you to identify dehydration states of the patient, as well as your CBC, because as we had said, infection can precipitate diabetic ketoacidosis. All right. So that is an iron gap acidosis. We have now finished that. So let's go take a look at this question right over here. All right, the others, please respond. Okay, so let's take a look at this. Now, from now on, and the reason why I put this here is so that you will remember it. Whenever we have patients who have ketones of 2 or 3 or 4, they still are not going to be categorized as having DKA. In order to diagnose DKA, the parameter is that the serum ketone concentration has got to be over or above 5 MEQs per liter. So, in order to diagnose ketoacidosis, again, remember that the number has got to be 5 or above. MEQs of serum ketone. Now, sometimes some patients are going to have positive ketones in their blood, but they might just have 2 MEQs of ketone. They're not going to be diagnosed as having DKA. Remember that DKA mandates that the serum ketone concentration has got to be over 5 MEQs per liter, or 5 or above. All right? So remember that just because you have ketones doesn't mean to say that you have diabetic ketoacidosis. It's got to be 5 or more MEQs per liter. So let's now go to the treatment of diabetic ketoacidosis. The treatment for diabetic ketoacidosis is easy to remember because it must always follow the acronym DKA. Okay, so the priority is treating the dehydration first. The second is to treat the potassium or the electrolyte problems first, next. And the last one is to treat the acidosis. So let's take a look at treating the dehydration. So whenever we have patients who are manifesting DKA, we already said that they're going to be dehydrated. And therefore, it is imperative that the fluid losses will have to be corrected in order to correct the other problems, namely electrolyte problems and acidosis. So the total volume of fluid or that we usually give would be around 40 to 50 mLs per kilogram. So the fluid that we would give to these patients are going to be normal saline or Ringer's lactate. And in severe cases, a bolus might be needed. And over here would be in the regular cases. So this is going to be important. We would monitor the anion gap. This is the primary lab you want to follow to see the resolution of ketoacidosis. So again, how do we evaluate whether or not our fluid resuscitation is doing good or bad? We monitor the anion gap. All right. So the anion gaps should return to around 10 to 12 milliosmoles. Okay? All right. Now notice that I'm going to go to another slide to just further explain this. So again, we're going to use isotonic sodium chloride or Ringer's lactate. And once the patient now has a good volume of fluid, and the way we monitor this is the blood pressure returns to normal or the CVP returns to normal, we would now switch the patient to 1/2 normal saline. Okay, so why do we want to have or to give 1/2 normal saline? So if you remember, there are 3 types of solutions that we usually give as IV. And they're classified as isotonic, hypotonic, and hypertonic. So let's take a look at each one of them. So first of all, isotonic. So isotonic means to say that if this is going to be the concentration of the solution that you're giving, so let's say 4 particles, it's also going to be equal to the particles right over here. So 4 particles over here, so they're equal, iso meaning equal. So that means to say that fluid will go back and forth. Nothing is sucking in. Okay, so this is isotonic. Now, if you have 4 particles in your cells, but you give a solution that's only going to be 2 particles, this is going to be hypotonic. So what would be the movement of fluid in this particular instance? Well, when you give a hypotonic solution, the fluid will go to the cells because the cells are going to be much more concentrated. Okay, so that this is a hypotonic solution. And the last one, the hypertonic solution. A hypertonic solution would be, let's say that you are having a IV and you gave a lot of particles right over here, and you only have 4 particles in the cells. So water is going to be drawn away from the cell. And therefore, this is going to decrease the amount of fluid from the cell. Okay, so this is hypertonic solution. All right, so my question is, if you want to bring water into the cell, would you give an isotonic solution, a hypertonic solution, or a hypertonic solution? If you want to feed the cell, what type of solution will you give? Would you give an isotonic solution? Like, for example, let's say a half normal saline, a hypotonic solution, sorry about that, normal saline. This would be a half normal saline, and this would be 3% normal saline. Which one would you give to feed the cells? Everybody's got to respond. Would you give normal saline, half normal saline, or 3% normal saline? Anybody? 1/2 normal saline. Very good. You would want to give a half normal saline because you want to feed the cells. Okay. Now, let's say that you have a lot of edema, like a cerebral edema. What would you want to do? You want to give a hypertonic solution. You want to take out the volume of fluid in the cell. Okay, so that's exactly why when the patient now is going to be normal euvolemic, we're now going to switch them to 1/2 normal saline. Because now what we want to do is not only to expand this volume in the blood vessels, but we also would like now to feed the cell right here. Okay? And so that's 1/2 normal saline. Now, as soon as the blood sugar reaches to around 200 to 250 milligrams, what we're going to have to do is we want to give D5 or D10 normal saline with 1/2 normal saline. Dr. Tom, are you crazy? This patient was hyperglycemic, and now you're giving dextrose again? Well, why is that? Well, we want to make sure that we are going to prevent hypoglycemia. Because if you develop hypoglycemia, what's going to happen is, again, it's going to precipitate other things that might worsen the condition. So we always add dextrose because in addition to that particular reasoning, we also need to maintain metabolic fuel. And that is the reason why we start giving dextrose along with the 1/2 normal saline. So this is a common question in Nclex. The question in the past has been, a patient was on DKA and now the physician orders you to change the IV to D5 1/2 normal saline. What would be the appropriate intervention? The appropriate intervention is to follow the order because it is an okay order, because you want to maintain a metabolic fuel source for that patient. Okay? So do you understand that now? That we, despite the fact that it began with hyperglycemia, we're now going to give dextrose to the patient once the blood glucose is going to decrease to around 200 or 250 milligrams per deciliter. Okay, so the fluids are going to be the first one that we have to do, because if you remember that slide over here that says we have to treat the dehydration first, this is going to be the priority, okay? Now, the second thing that we're going to do is to treat the electrolytes. And so whenever we treat electrolytes, what we're going to do is to correct the potassium first of all. So that's the most common thing or common electrolyte that we're going to have to correct. So let's take a look at this question so that we can discuss electrolytes. Okay, so the correct answer here is letter B. Let me just digress a little bit so that you can understand why letter B is the correct answer. All right, so normally when you have this blood vessel, bloodstream, and you have glucose right over here, you remember that glucose can enter the cell only in the presence of insulin. So if you give insulin, what happens is that the glucose is going to now be able to be transported into the inside of the cell. However, every time a glucose goes in, what's going to happen is it also pulls along with it potassium. So potassium, along with the glucose, will go into the cell. All right. So in our situation, we had a patient that had a potassium level of 2.5. So here's the situation. This is your bloodstream, and this is your cell. And the potassium here was 2.5, which is very low. Now, when you give insulin, what would happen to this potassium? This potassium, along with the glucose, will now go into the cell. So therefore, this 2.5 will now become 2 or 1 or something like that. So that means to say that you will now have worsening of the hypokalemia. So it is imperative that Whenever insulin is given, it helps to take potassium back into the cell, which will cause potassium blood levels to fall. So we never start giving insulin to the patient unless the patient's potassium level is 3.3 or greater. So do you understand now why the hierarchy of treating your diabetic ketoacidosis is DKA? Number 2 is potassium. Because what we need to do is, first of all, make sure that we do not worsen the hypokalemia. So in that particular question, therefore, holding the insulin and notifying the MD of the potassium of 2.5, because you're going to be concerned that this potassium is going to decrease further. And what's the danger if you have a decrease in potassium? Well, the most dangerous thing that could happen is that the patient can develop cardiac arrest. And that's the number one consideration. Okay? So the treatment of your potassium is going to be the following. Where is that? Right here. We would like to make sure that electrolytes are going to be normalized first before we give insulin. Okay, so let's now go to insulin therapy. This is the one that I'm looking for. So electrolytes, we want to monitor the potassium hourly, and usually we could give potassium supplements, and they usually are going to be a combination of potassium chloride as well as potassium phosphate. And again, we always start with fluid replacement. Along with fluid replacement, if the potassium is going to be between this level, we give 10 MEQs. If it's less than that, we give 20 MEQs as a bolus drip. Okay, and now let's go to the treatment with insulin. So what are the parameters as far as treating the patient with insulin as far as DKA is concerned? Well, what kind of insulin should you give? Well, only short-acting insulin is used for the correction of hyperglycemia. And subcutaneous absorption of insulin is reduced in diabetic ketoacidosis because of the dehydration. It therefore is the reason why we prefer to give the insulin by the IV route. Okay, so the initial dose of insulin is going to be a continuous infusion, and it usually is going to be at a rate of around 0.1 units per kilogram per hour. And you don't have to memorize this, but it's just to give you an idea of how we treat them with insulin. And of course, once the blood glucose is less than 180, we now decrease the infusion in order to prevent hypoglycemia. Okay? And so we never allow the blood glucose to fall below 200 during the first 4 to 5 hours, because if you rapidly correct hyperglycemia, you will develop cerebral edema. Okay? All right. And now if blood glucose falls below 50, obviously we want to add 10% of dextrose in order to prevent hypoglycemia. Now you might be wondering, should we give patients who have diabetic ketoacidosis sodium bicarbonate? Well, sodium bicarbonate is not going to be the appropriate treatment in these patients because the acidosis was caused by an increase in acids and not a decrease in bicarb. And that's the reason why we only use it if it is going to be necessary. But in normal circumstances, sodium bicarbonate is not going to be the appropriate treatment. And the other reason for that is if you give bicarbonate, it worsens hypokalemia. And so that is the major reason why we do not use sodium bicarbonate to treat the acidosis. How about the others? Okay, very good. All right. So a patient was admitted with diabetic ketoacidosis and has the following lab values. So we already know why the glucose is going to be high, but this one, potassium of 3.3 is something that we need to be worried about because normal potassium is 3.5 to 4.5, right? Now, if I give insulin to this patient, what's going to happen to the potassium? If I give insulin to the patient, what's going to happen to the potassium? The potassium will come down again. Because you remember, every time you have glucose going in, and glucose will go in the presence of insulin, it also will carry with it potassium. And therefore, you always treat the hypokalemia first before treating the hyperglycemia. Okay? So the correct answer is letter C. We need to give potassium chloride first. And again, we said that bicarbonate is not going to be an appropriate treatment in patients who have diabetic ketoacidosis. Okay, one complication of diabetic ketoacidosis, and usually is going to be a cause of high mortality, particularly in children, is cerebral edema. This is as a result of hyponatremia, and the manifestations of cerebral edema are all neurologic, and they might include abnormal responses to pain, the corticate or the cerebral posturing, as well as abnormal respiratory patterns and bradycardia. So when you detect this particular symptoms of cerebral edema, that means to say that the patient has now hyponatremia, and therefore has to be treated with the measures to decrease cerebral edema. So what are some of the measures to decrease cerebral edema? Well, you remember what I said about the different kinds of solutions. We have isotonic, we have hypotonic, and we have hypertonic solutions. So in cerebral edema, this is the blood vessels. The normal size of the cell was supposed to be like this, but because of the edema, it's now going to be like this. So how do you treat this? Do you treat it with isotonic, hypotonic, or hypertonic solutions? What kind of a solution will we need in order to treat the cerebral edema? Iso, hypo, or hypertonic? Hello. Hypertonic. Okay. So hypertonic solutions that we often use are D10 in water. And the other one you might have heard is another IV fluid called mannitol. And mannitol is a hypertonic solution. And this is the treatment for patients who display symptoms of cerebral edema. So when we have cerebral edema, we usually give D10W and mannitol. And in so doing, what we're going to attract the fluid away from the cells and therefore eliminate it through the vascular bed. Okay? So the treatment for cerebral edema is the administration of mannitol or even hypertonic solutions like hypertonic saline, which would be 3% saline. Very good. Yes. Hyperkalemia is going to be the one that we're going to be, hypokalemia is the one that we're going to be concerned about. Okay. All right, very good. So the correct answer is letter A. Now, in diabetic ketoacidosis, ketones are going to be present in the urine. And then, of course, metabolic acidosis with Kussmaul's respirations is going to be noted. And the potassium of 3.3 be above 3.3 before we treat them with insulin. The correct answer is letter A. This is a good introduction to the other complication associated with hyperglycemia, and that is HHS. And that's exactly what we're going to be talking about next. It's called hyperglycemic hyperosmolar syndrome. Okay, so there's a difference between DKA and HHS, and it usually is with the levels of blood glucose as well as the presence or absence of ketones. All right, you're all correct. Letter D is the correct response. They need to check their blood glucose every 3 to 4 hours and maintain hydration when they are sick. Okay, so we now go to the next presentation or the next complication associated with diabetes, and that is HHS, which is hyperosmolar hyperglycemic syndrome. And it used to be called by many names, like non-ketotic hyperosmolar coma, but it doesn't necessarily accompany coma, and that is the reason why we only refer to it now as hyperosmolar hyperglycemic syndrome, or HHS. So this is the other complication that occurs in patients with diabetes mellitus. And it is a life-threatening emergency. It is less common than DKA, but it has a much higher mortality rate compared to DKA. So the characteristics of this particular state or complication is going to be hyperglycemia, hyperosmolarity, and dehydration that is not accompanied by ketoacidosis. Okay. So whenever we have this particular syndrome, we're going to have the same amount or the pathway as far as the pathophysiology is concerned. So I'm not going to go through this again, but what happens is that it's going to be characterized by two things, okay? And the first one is hyperglycemia. Mhm. And hyperosmolar. All right. So whenever we have patients with HHS, their blood glucose is usually above 600 milligrams. It's very rare that this occurs in patients with diabetic ketoacidosis. And the hyperosmolarity, usually their plasma osmolarity, could go up to about 310. And usually it's around 280 to 300 is normal osmolarity. But in these individuals, they're going to have an increase in their plasma osmolarity. So again, what is plasma osmolarity? You remember what I drew earlier, supposing that you have this type of blood vessel and compare this to this blood vessel that has a lot of particles. This is more concentrated right here, and this therefore has a higher osmolarity. So osmolarity is the concentration of solutes in a liter of fluid. It's the same as osmolality, osmolality, but this is per weight in kilograms. So that's why we use this much more often. Okay, so in patients with HHS, they usually have a very high plasma osmolarity, which means to say that it is going to cause cellular dehydration. And I hope that you understand now why there's cellular dehydration. Because if this were the cells and they only have two particles right here, this is going to be much more concentrated. The fluid will go into the vascular space. So the prominent manifestations of HHS will be dehydration, along with neurological signs and symptoms and excessive thirst. Okay, so there's a difference between DKA and HHS, and let's take a look at the differences between the two. DKA will occur very rapidly. However, in HHS, it's going to occur over several days. So it's slower in its onset. And then, of course, the signs and symptoms of DKA are almost the same as your HHS. But in addition to those symptoms, you're now going to have neurological symptoms. And the reason why you have neurological symptoms is because you remember, if this was the brain, and now you have a very hyper or smaller solution in your blood vessels, the brain will now shrink because you are now taking out the fluid away from the brain. And that is the reason why you will have neurological symptoms such as lethargy, seizures, obtundation, and coma. Okay? Now, the other thing that is going to be different between DKA and HHS are the following. In DKA, it usually is going to occur in absolute or near absolute insulin deficiency. So which means to say it's much more common in patients with type 1 diabetes. Whereas in HHS, this is going to be more common in patients with relative insulin deficiency, meaning to say that this is going to be much more common in patients with type 2 diabetes mellitus. And, oops, sorry about that. Oh. Lastly, what I wanted to underscore over here are the lab values in each of these presentations. In HHS, you could see that the plasma glucose is going to be a lot higher. You're going to have, of course, over 600. In DKA, the elevations of blood sugar is not that much. And as you could see, as far as ketones are concerned, in HHS, it is minimal. But in DKA, it's going to be present, meaning to say that the level of ketones is 5 MEQs or greater. Okay, so those are the differences between the two. And so let's take a look at some questions. Sorry about that. Patient with an infection. Okay. All right, this was a little bit tricky because it tries to test you whether or not you understand the difference between type 1 and type 2 diabetes mellitus. Okay, so in type 1, what is the treatment for their condition? Usually it's going to be insulin, right? In type 2, what is going to be their major therapy? It usually is going to be oral hypoglycemics. And metformin is an oral hypoglycemic agent, which means to say that this patient is a type 2 diabetic, and therefore they're more at risk for the development of HHS or hyperglycemic hyperosmolar syndrome. All right. So the correct answer is letter A. So both of you missed that. That's because you forgot that metformin is an oral hypoglycemic agent, and therefore the patient is most likely to be a type 2 diabetic. Okay, so the correct answers here are B, D, and E, and I will explain that in a little bit. Now, whenever your body is not going to be getting enough fuel, then what happens is that the body now activates the stress response and it increases glucagon secretions. And that is going to be your hyperglucagonemia. And then, of course, the body will also look for other sources of energy, and they now are going to break down fat. Fat is going to be the one that is going to um, be another thing that's lipolysis, and other compensatory mechanisms will be to break down stored glucose. And what is stored glucose? Stored glucose is going to be glycogen, and usually the majority of glycogen is going to be present in your liver and also muscles. So hepatic glycogenolysis contributes again to the increase in blood sugar in patients with HHS. And of course, because of their insulin deficiency. So the question is really asking you, why is it that patients with HHS have a very, very high blood sugar? Well, why is there massive hyperglycemia? And these are the answers that are B, D, and letter E. Okay, so the signs and symptoms of, again, HHS are going to be similar as DKA. The thing that's different is, of course, your neurologic changes. So these are ones that are going to be much more common and not present in patients who have diabetic ketoacidosis. All right, so you remember what we said about bicarbonate? It's not a deficiency in bicarbonate, and therefore we do not give bicarbonate to these patients. We still give isotonic fluids. You remember once the patient is going to be euvolemic, or the blood pressure now has returned to normal, we could go ahead and give them normal saline, but the ideal is to give also half normal saline in order to feed the cells. Very good. As we are treating the patient with the severe hyperglycemia, what happens is that water now can start moving back into the brain cells. And the danger, of course, is going to be that cerebral edema can occur. And that's the reason why we have to watch them very carefully. Okay. Very good. The blood glucose of 600 is a giveaway. So that means to say that this is going to be more HHS rather than DKA. Okay, so the correct answer here are your diuretics. You remember thiazide diuretics, they're very common in causing an increase in blood sugar, as well as beta blockers. So letter A and letter B are the correct responses. All right, so you understood that in HHS, there's not a um, significant levels of ketones, and therefore Kussmaul's breathing will not be appropriate. Okay, so the treatment is the same, and so that ends the presentation. So let's now go to this case study. So you have a 73-year-old male with a history of diabetes type 2 brought to the emergency department by spouse for changes in mental status from his baseline. The client's wife reports that he woke at 6 o'clock to complete his morning routine. At approximately 11, he became unaware of his surroundings and began sweating profusely and slurring words. Breath sounds are clear but noted with a fruity citrus odor and deep rapid respirations. Sinus tap per cardiac monitor is awake and alert, pupils equal and reactive to light. All right, so the vital signs are displayed as well as the medications that the patient is on. So let's go to the first question. Which of the findings are going to be significant? And we are supposed to only choose 4 findings that are most significant. So the lung sounds are clear. Respirations is 32. The pupils are equal and reactive to light. The temperature is 99.5. And the mental status is that he is awake and alert. Pupils equal and reactive to light. I'm going to end the poll because you are not able to see the question. So let's take a look at the question over here. So at 12 o'clock, this, that was the one that I read, right? And the vital signs and the medications. Okay, so let's do it together. Lung sounds, are they going to be significant? The lung sounds are clear. So this is not going to be significant. Okay. So we're thinking about this this change in the mental status of the patient with a citrus odor. And so we should be thinking now that maybe this patient has a complication of diabetes. So the history of diabetes would be significant. And the respiratory status, if we see over here, it says that the status, the fruity citrus odor and deep rapid respirations. So this should clue you to the fact that maybe this patient has Kussmaul's respirations. So this respiratory status is going to be of concern. And then, of course, the circulation, the blood pressure is 97/66. This might be something that we might be concerned about. The pupils are equal and reactive to light, so that's going to be okay. The temperature is a little bit elevated, but not really that elevated. But the mental status is something that is going to be of concern. The medications, sitagliptin and metformin, is a diabetic oral anti-diabetic agent, and valsartan is for hypertension. So the correct answers here are history of type 2 diabetes, respiratory status, and circulation, as well as mental status. So now the nurse starts an IV and reviews the labs. The labs are displayed over here. For each finding, click to specify if it's consistent with ketoacidosis or hyperglycemic hyperosmolar syndrome. Okay, so let's go back to here because I think I wrote the values Okay. Okay, so let's see. The pH of 7.20, you remember ketoacidosis, which means to say that this would be present in DKA and not necessarily in HHS. The blood glucose, which is going to be 435, this is higher than the usual, and therefore this would be ketoacidosis. Remember that the serum blood glucose levels in DKA can fluctuate between 300 to around 350. It's typically above 600 in patients with HHS. And your serum creatinine is going to be reflective that this patient is dehydrated. So it could be present in both. And then, of course, the urine is the one positive ketones over here is going to be much more characteristic of patients with DKA. Okay, so now we have 12:15. The patient voided 30 mLs of dark amber urine, sent for urinalysis. The comprehensive metabolic panel, CBC and ABG, IV abnormal saline started, 2 liters oxygen per nasal cannula, and the capillary glucose is now 440. Okay. So complete the sentence. The problem the nurse should address first is. I'm glad that you remember that. The priority is to restore volume so that we can maintain tissue perfusion. And once the volume is improved, then we can start treating the hyperglycemia with insulin. Okay, very good. So the correct answer is letter B, restoring volume. So the client now is diagnosed with ketoacidosis, and the nurse will now begin the plan of care. Okay. So for each nursing intervention, click to specify whether the intervention is indicated, contraindicated, or non-essential. So when we say non-essential, it's not important at this time. Okay, let's see how we should answer this. All right. So the first one is obtain glycosylated hemoglobin A1C. So what is hemoglobin A1C? Well, this is going to be very useful to see the 3-month glucose control of a patient. And we don't need that right now, right? So therefore, it's non-essential at this time. Um, it's not indicated for us to be able to treat this person effectively. Teach the client pursed lip breathing. And I think that's one thing that I had talked about before. I think it was yesterday, that pursed lip breathing is something that's very useful in patients who are going to have respiratory distress of some kind or another. So pursed lip breathing will help slow down the pace of breathing. And therefore, this would not be a this is an indicated uh, intervention. Administer insulin glargine subcutaneous. Now, what is insulin glargine? This is going to be a type of insulin, but it's a long-acting insulin that is injected once daily and actually provides basal dose of insulin. So therefore, administering this will not be useful. It actually is contraindicated. All right. And inserting a Foley catheter is not going to assist us in any way. And as you remember, with CAUT being a problem or catheter associated urinary tract infection, we usually are not going to routinely insert a Foley catheter. Administer IV potassium. Well, as you could see, the potassium is 3.4. So therefore, this would be indicated. And of course, because this patient is in a serious condition, we want to make sure that we monitor the ECG. Okay. And now let's go to the last question. No, the second to the last question. The nurse reviews the order. What action should the nurse take while implementing the treatment plan? Select all that apply. Okay, so the orders are above. All right, should we start insulin right away? And the answer to that is no, right? So should we hold insulin for low potassium levels? And the answer to that is yes. And should we request IV fluids with dextrose when the glucose start to normalize? You remember this is very important in order to prevent hypoglycemia. And then, of course, we always allow the patient to eat when the status stabilizes so that we can prevent hypoglycemia. And of course, we always monitor this patient for symptoms of fluid overload. And the last question that we have is the nurse reassesses the client after giving a fluid bolus and starting the insulin infusion. Which findings indicate that the treatment plan has been effective? Select all that apply. Okay, so if we take a look at the blood pressure, it was 97/66, and now it is 109/70. So this means to say that this is a manifestation that the interventions have been effective. As far as the mental status is concerned, it says over here that the patient now is awake, alert, and oriented to person and place. So that means to say that this is a good sign that the patient is having a good resuscitation. Now let's take a look at the breath sounds. Breath sounds are clear, but over here, the breath sounds are also clear. So there's no change at all. And the pulse rate is now 100. It used to be 118, and now it's 100. So that means to say that the pulse is a manifestation that what we're doing is okay. How about the capillary glucose? Well, the capillary glucose was, let's see, over here was 435. It was 440 before. 435 at 1330, and then it's still 435. So that means to say that there has not been any change as far as the capillary glucose is concerned. And then pain was not a primary issue, and therefore that is not going to be relevant. So A, B, and D are the correct responses. So I know that there's only three of you now that are left. I want to thank you again for your participation, and I look forward to seeing you on Tuesday next week. And I look forward to having you again. Thank you so much for your participation. Have a great night. Okay? You're welcome. Thank you, Annie and Lynn. Have a great evening. And Marie.